Hi, we are going to have a little micro lecture. And so these are what we like to call our ticket to class. So these are not big topics. These are small little categories of things. In this case, we're talking about treatment of dysrhythmias for the bradycardic rhythm. So what these do are these little lectures are maybe 20 minutes, maybe at the most 30 minutes, and they're quick. They're focused on one topic only, and they're meant to kind of give you an overview of what we're going to be talking about. Sometimes they take the place of a topic in lecture that we just couldn't get to, or something that is really not worth kind of focusing our time in class on, but we do need to have some knowledge to be aware. So what this lecture is going to do is introduce some terminology. It's going to introduce some of the mechanics of how to use different devices to treat different arrhythmias so that when you come to lab, we will show you in person how to use some of the equipment. So what we're going to start with are the treatments of dysrhythmias. Okay, so we are going to start with the bradycardic rhythm. So these are going to match what we talked about yesterday. So we're going to talk about, we introduced the different bradycardias and we introduced these heart blocks and things. So what do we do to treat them? And that's what this is going to be focused on today. So when we talked about things that were bradycardic, when we're talking about a rhythm that's lower than 60, especially those that are symptomatic, showing that we don't have enough cardiac output, we're starting to be symptomatic. So one of the three things that we can do for medications we're going to talk about, the first one is atropine. This is a medication that is what we call our first line treatment for bradycardia, means that's the first thing you go to. And what this does is it helps to kind of reverse the cholinergic reaction that is causing the heart rate to drop. So we use this, and we're going to talk about ACLS. We're going to talk about this a little bit more in lab and in lecture and upcoming. And so what this is advanced cardiac life support, which is kind of the gold standard from the American Heart Association, that anyone who has to do with trauma, with cardiac, with anything, all agree that this is the most current science. And this is what we kind of base our algorithms. Again, we're going to talk about that, what those are all based on. So if you have a patient who is symptomatic with bradycardia, our first thing we're going to do is we're going to break out the atropine. Okay, we're going to give a milligram bolus, then we're going to wait and see what happens. And the hope is that this will speed things up. Another medication that you're going to hear us talk a lot about, move myself to their side here, is epinephrine. And this is something that not only does it speed up the heart rate, but it also increases the contractility or the squeezing power of the heart itself. And that also will increase your cardiac output. So this is our go-to for a lot of rhythms. And we're going to talk again about this medication next week. We'll have another little micro lecture before you go to lab. This isn't our first line for bradycardia, but it's our first line kind of for everything else. So you're not wrong if this is one of the things that you're considering, right? So this we do as an infusion, or we can do it as an IV push. And when you watch Grey's Anatomy and Chicago Med and all those things, a lot of times they'll say epi, stat, this is what they're talking about. So this is a medication that you can give either IV push or IV infusion. You can give it nebulized. We'll talk about that when we talk about anaphylactic shock, right? Angioedema. It can also be given down the endotracheal tube if they're intubated and you don't have any access. You can give it IO if you're tapping into the bone. Again, we'll talk about all this stuff later, but I just want you to start to understand the medications and the terminology that we're going to be using within ACLS for different things, and then also to treat these dysrhythmias. Okay. The last one we're going to talk about is dopamine. Now, that's the triad of the medications, and this is a vasostimulant, right? So this causes everything to kind of vasoconstrict, which increases our blood pressure, increases our heart rate, and we use it to treat also for people who are having cardiac arrest. So we kind of do this in two different doses. There's a low dose, or sometimes we call it a renal dose, and that kind of helps for perfusion, right? It kind of increases the contraction of the heart, ups the heart rate a little bit, increases the blood pressure. And then we have another dose, and this is when we're using it as a vasopressor, right? This is really going to clamp everything down, which then squeezes all the blood back to the heart so we can get better cardiac output. This we use an IV infusion, and we titrate it, meaning we adjust the dose based on our symptoms and our outcomes on what we want to have accomplished with this patient. So those are the three medications that we're going to primarily discuss today, all right, in lab. We're going to talk about it. But here's the other thing that we sometimes need to use our external devices, and we're going to talk about pacemakers. Now, I know you know what a pacemaker is, and I'm sure you're familiar with it, but we're just going to go over the basics, right? When you're in lab, we are going to go over how to use the life pack, what's the difference, what buttons, what are the rate do we use, those type of things. But just to kind of get an overview. Okay, we use those when the heart rate is either too slow or it's too irregular and our cardiac output is compromised. So all the things we're trying to do is establish homeostasis. We want cardiac output that's going to support the body, right? But keep everything perfused. That's our goal. The goal is tissue perfusion, right? So we support what's already going on with the electrical system. We kind of stabilize if something's really out of whack. And we make sure that the heart rate is going enough that we've got perfusion, right? And so we can either put these leads, as we call them on the pacemaker, wires that right go into the heart muscle. We can do them single or we can do them in dual, right? There's actually a third way that we can even use, and we'll talk about that in a minute, but all of them involve wires going into the heart and activating directly in contact with the heart muscle to keep it going. Okay. When we talk about the mechanism, right? So in this picture, you can see three different things. So we can talk about a single, a dual, or a biventricle, right? And so what that means is what part of the heart is actually being activated by this pacemaker wire, right? Where's that impulse coming? Because what that pacemaker is doing is it's substituting where that SA node and that AV node and all those Purkinje fibers and everything's supposed to travel through that electrical pathway. We know something's not right. So this is a substitution, right? Where the pulse generator comes from either a generator source, an implantable, or from the life pack or whatever we're using. And then wherever the wire goes, that's where that pulse is going to generate from. Okay. So single chamber, if you look in that picture in that top right circle, that's where we put a wire into one side. Typically, it's going to be the right atrium or the right ventricle, and we're going to stimulate that area directly. Okay. We can do a dual chamber then, which is two leads, right? So I do the right atrium and the right ventricle, and we time them up so that they beat in sequential order so that they're not, everything's not squeezing at once. There is an opportunity though, when we would do a biventricle pacemaker. Okay. And so this is something you don't see that often. This is for people with pretty advanced heart failure. And that was where you'd put two leads in the ventricle themselves and you would resynchronize so they would squeeze together. And we'll talk a little bit about that. But what you're mainly going to see and what we're going to reference, we're going to talk about the single and the dual. Those are the two main ones that you're going to see. Okay, so again, when do we use this? When they're symptomatic. That's the main thing, right? Because if you can compensate on your own and your cardiac output isn't too affected, we might go with other options. But if we're symptomatic for bradycardia and heart blocks, that sick sinus syndrome, remember they got those long pauses where nothing's happening. Obviously, you're not perfusing if it's not squeezing. After we have an MI or have cardiac surgeries, or then with congestive heart failure. So the first thing we're going to talk about are the permanent pacemakers. And I think this is what we think of when we think of pacemakers, right? We've got that pocket in the subcutaneous area, usually on the left side, right underneath that collarbone. You can feel it. It's got a nice, hard metal ting to it. That is your implanted, right? That's kind of what we think of. And then we also have the pacemaker ICD, which is the ICD looks the same, but in addition to pacing, or sometimes in lieu of, maybe what doesn't pace at all, but when your heart would enter lethal rhythm, it detects that and it can actually shock. Right. So what you see on the movies where they say clear and they shock the body, they do this internally. Right. So this is the implantable defibrillator. And that is a life-saving measure, right? There's another type that they can do. It's called a leadless pacemaker. And that is where, like you do with a heart cath, you would thread a transducer through the groin or through the wrist, and you would go into the heart muscle itself, and you would put that lead right into that heart muscle and it would stay there and it would not have to go through a long wire, right? It's just like a little capsule and it would sit right on that muscle. So if you wanted the atrium to be paced, you would lodge it right on that heart muscle in the atrium or the ventricle, right? And so since they only do one at a time, right, if you need a dual chamber, you would just use two leadless pacemakers, okay? And we'll talk about how those are good or bad, and the advantages and disadvantages of that going forward. Okay. Another thing we could have is a temporary pacemaker. And this is something that you will see depending on where you're at. Okay. Whether you're on a step down unit, whether you're in the post heart transplant or heart surgery unit, there's lots of different things. So the first one we're going to talk about is a transvenous. Okay. And that is when you are floating a wire in, and you're doing it under fluoro, and you're watching it kind of hit that ventricle or hit that area, and it will actually pace. The wires will come outside the body. Okay. um and you'll have a little module you can see there where it's got the little devices on it. This is very much what you're going to see on that life pack. Okay, but this one is just for the transvenous pacemaker. The transcutaneous, instead of floating the wires in through the vein, right, we're going to put them stickers front and back. And we've seen those a lot on TV, and we're going to experience these in the lab as well. There's another one that is an epicardial pacemaker, and this is where these wires have like little hooks on the end, right? So if you like crochet, or you've seen like those little curvature at the end. And so what these are during cardiac surgeries, a lot of times they irritate the myocardium, right? So we do open heart surgery, we're in there messing around with the heart, we get it kind of irritated. So because of that irritation, we know that it's more prone to arrhythmias. So what they'll do is they'll leave these little hooked wires right on the end. Okay. And then again, you'll see those wires come out and they'll go right to that little pacing box, and they'll be able to control it. So that way, if they do have any type of arrhythmia, if they do have some VTAC, if they have anything, if the heart rate's too low, they can dial it up, dial it back. And then once they're sure that the heart looks good, they literally can just pull a little bit and those wires dislodge. Okay, so these are temporary. Sometimes you can just stay with these, right? And you'll fix what needs to be wrong. Other times they need to be implanted. So different types of pacemakers for different indications. So what you probably are most familiar with a temporary pacing situation would be transcutaneous pacing. And that has to go through the skin. So this is fast, it's efficient. We're not doing any invasive, we're not going through the vein or the groin. And we can use this on somebody who's conscious. So if you have a patient that came back from surgery, or say you're in the emergency department, and they start to have symptomatic bradycardia for something, you can go ahead and put these on, hook them up to the life pack, and you can pace right there. Okay, very simple, very effective. We do need to remember though that this can be painful. Okay, so we do want to make sure that we medicate them, because it is electrical impulse. It's not a full defibrillation, it's not the full shock, but it can be uncomfortable. So we do want to make sure that we medicate them for that. Okay, so I'm going to share a quick little video that just kind of outlines what we are looking at as far as um, pacing on the life pack. Okay, so hang on one second here and get this to work. Bear with me here. Technology is great when it works. And share. All right. So you can see in this video here. So if you look at the monitor, you can see that this is a life pack, right? And you can see that the heart rate itself is 37. And we know that that is probably not stable. 37 is a pretty low rate. On the right side of that little monitor, you're going to see a green button, a black button, a yellow button, and a red button, okay? And you're also going to see a little dial with a little wheel. This is what we're going to do in lab, is we're going to learn how to do this so that you feel comfortable. Okay, so I'm just going to play this real quick.
An unstable third-degree heart block. Here's how we're going to pace this patient out of this. We're going to pace with the pacer here. We're going to choose a rate. I'm going to go to 75. Next, I'm going to choose the current. I'm going to bring the current up. My goal here is to get what we call capture. We want the patient's pulse eventually to match the current and the pacing of the monitor. I'm going to go to 75 and see how it looks. So I can see it changing here on the screen right in front of my eyes, and I can see the pacer spike right in front of it. Looks good to me. I'm going to click it. And now we are pacing the patient at 75. Now what you're going to do is check the patient's pulse to make sure it matches up. And there it is. Follow my
Okay. So you can see on that screen, you could see where it was 37, and you saw with a few quick clicks, you could see that they dialed in, made a few selections on rate and on the amount of voltage, and next thing you know, the patient's rate is at 75, right? So that's how quick transcutaneous pacing can be, and that's why we like it because it works really quick and it's super effective and really not a lot of margin for error, right? Um, if you look at these videos on these next few slides here, this video here is where they already have the implantable pacemaker in the pocket. Because when they do these surgeries, what they do is they make the pocket first and they get it all situated. And then they will attach all the little devices that need to be. So the leads are in place, they put the pacemaker in place, and then they snap everything together, put it back in the pocket. So there's a video that shows that. And here's a couple different options as well. So we have the transvenous pacemaker, the implanted pacemaker insertion, and the leadless pacemaker. So if you're interested in what those look like and you're a visual learner and you really are interested in like, okay, so okay, I get what you're saying, but what does that really look like in a real patient? Here's some videos you can watch. And they were pretty informative and they do a good job of explaining and showing what everything looks like. So, how do you know what type of pacemaker you're going to need, right? So we talked about the single chamber, the dual chamber, and the biventricle. How do you know what you need? So when you need a single pacemaker, a single chamber, that is where you put the lead in one spot. So typically what this is going to mean is that you have damage or a faulty area in one aspect of the heart, right? So let's say the SA node just is not generating what it's supposed to generate, but the AV node itself is healthy and the Purkinje fibers are very healthy. So you go ahead and you insert that one lead into the atrium, right, to take the place of that SA node. And then when it generates electricity from there, the heart knows to carry it through the rest and squeeze, and you've got it, right? Same thing with the ventricle. Maybe the SA node's working great, but that AV node is faulty. And even though that signal's getting to the ventricle, it's just not dispersing like it should. So kind of a one node problem, you can go with a single chamber, a single lead. For those hearts that are a little bit sicker, maybe a conduction system that has a few more blockages, scar tissue, abnormalities, congenital disorders, this is where we need both. And what we do is we put it in both the atrium and the ventricle, and that takes the place of the SA and the AV node so that it will squeeze. Again, we want it to squeeze sequentially, right? That's what the AV node is. It's a junction box. So the SA node generates, it gets to that AV node, pauses for a second, then goes through the rest of the heart. That gives the muscles times to polarize and depolarize so that it squeezes correctly. Okay. And again, the third thing that we talked about was that biventricle. Now, this is something that you're not going to see super often. But there are certain arrhythmias that are caused when a patient is involved in advanced heart failure. Okay. So this is not something that we would do for, oh, we'll try this option, right? This is one of those like, we are resyncing how the heart squeezes and we're kind of short circuiting what it normally does in an attempt to get a better output. Okay. So this is not something that we're going to use all the time, but it is something that you do need to be aware of. Okay. So, let's say you have a patient that has a pacemaker and you don't know how to tell. Is it an atrial, right? Did we go through the top? Is it attached to the atrium or is it in the ventricle? So if you look at these two clips here, the one on the top is atrial paced, right? You see that line, right? That little spike. And then you see a P wave and a QRS, right? And then you see the repolarization and then you see that little spike and then it repeats. So when it is atrial paced, that QRS complex, right, looks very narrow because the intervention is happening that generates the electricity and then it goes through. If you look at the lower strip here, you will see, and you have to look kind of close here, there's a little tiny P wave. Then you see a spike, and then you see a wide QRS. Okay. You know that it is ventricular paced, and sometimes you'll even see a wide, and you're thinking, man, that looks like it's paced, but there's no spike on it, right? So maybe it's not. Check your lead, right? Check your monitor and see if you've like turned on that pacing function, and there you go. There's that space, right? That little pacer spike. Because it takes longer to hit that ventricle and then for it to get all the way through to the left side, that left ventricle, it's going to be wider because time, right? Time is what we're looking at when we're looking at EKG paper, the amount of time it takes for that current to get through the muscle. It takes longer, right, to generate through the right to the left. And so that's why it's wider. So an atrial pace rhythm is typically going to see a spike with a P wave, normal size, narrow QRS, whereas a ventricular pace is going to be a spike and then wide. Just a little hint. If you have both, right? If you have dual paced, you're going to see two spikes, and you're going to see a spike with a P wave and then another spike with a wide QRS, right? Because it's letting both chambers know it's getting its information, it's getting its electricity generated and delivered through the pacemaker, not through the SA and the EB nodes. So here's some terminology that I need you to know and be familiar with so that when you get to lab, you're not completely kind of blindsided by what we're going to show you. The first one is going to be pacing spikes. And remember, that's what I just talked about. That's that line that shows when the electrical impulse is generated, right? So straight line that you hardly ever see on an EKG, that's going to be your pacing spike, okay? Output, when we watch that video, when he was dialing up, that is how much electricity, right? How much current, and measured in milliamps, do we need to get capture, right? To get that heart to do what it needs to do. Sensing is when the pacemaker is reading what's going on in your heart, right? It has to know when to fire when there's no beat. So we need it to sense it. Okay. So that's why we call sensing. Capture, then, if all these things go together, capture is when you have the pacemaker spike and it is in the right place, the output is high enough, the heart is being, the sense is letting us know that there is no beat coming from the heart. And so we have the heart that actually beats based on what we're telling it to do. So the pacing spike is when we deliver that milliamp, right? We deliver that output. The lead has sensed that there is no heart activity, so we know it's good to go. And then capture is when we do electricity and then it does what it's supposed to do, right? We have a spike and then we see what happens. Now, here's the part that I need you to remember, that when you have capture, that does not mean that we're set, right? What do we need to do? Have to make sure we assess the patient, okay? Because we have issues. It's not foolproof. We do have some things we need to work on, okay? We could have failure to capture, and that is that we have a pacemaker spike and we have a whole lead of just spikes because either it's not the right time or that's the current's not strong enough to try to make the heart squeeze. So we could have like pacemaker spikes all day long, but until it captures, right? Until we see the heart squeeze, it means it's not really doing anything. We also have failure to sense, and that means that it's not correlating what's going on with your heart, right? Your heart might be beating fine, and all of a sudden the pacemaker goes, I should probably deliver a spike here, right? I should probably deliver that electrical activity. So you might see a spike in the middle of a P wave or a QRS, or the heart's not beating and it's not picking up on it. So if it's not detecting what's going on with the heart or sensing it, then we have another issue. The last one is we might have capture. We might have that line and we might have a beautiful QRS that goes through. But until we take the patient's pulse, we don't know if it works, right? We don't really care what's on the monitor. I mean, we care, but what's going on that monitor, just like PEA, right? Pulseless electrical activity. Anything that's going on that monitor could be gorgeous. But we got to look at our patient because if they don't have a pulse, I don't really care what the monitor's doing. We got to take a pulse, right? So, with everything related to your patient, every intervention that you try, we got to make sure that we are also assessing our patient, right? First step of the nursing process, assess, right? Always, always. So, please make sure that you remember that. Another thing that we could have would be an oversense, right? And that is it's getting some type of electrical interference from something. And the lead and the pacemaker are interpreting that as, oh, the heart's beating, right? And so if you've ever wondered why, when you walk through an airport, they have signs that say, if you have a pacemaker, please let us know, right? Electrical activity is in this area. And that is because the heart is super delicate and any extraneous input could actually affect the way the pacemaker is sensing. So anything that is electrical or magnetic is going to have an impact on your heart. So my husband has a pacemaker, and we went to Cedar Point, right? Took the kids to Cedar Point, mom of the year, didn't pay any attention to all those little signs because it was new that my husband had a pacemaker, and he wanted to ride the Millennium with the girls. I said, I'm going to stay here with my son. You guys go ahead. So my husband came back and he did not look good. He was green, he was sweaty, he was short of breath. And I thought, maybe the vertigo, maybe that the hill was too much for him, whatever. No, neither one of us had paid attention to the sign that says that the Millennium Force at Cedar Point is controlled by magnets, right? And that's what allows the car to go over the track and stay in the right place. It's held together by magnets that repel each other and magnets that attract each other. Well, once he got on the car and got locked in, he started feeling all sorts of activity from this pacemaker because that magnetic field, even though you can't see it, right? Because he was sitting in the seat, he was absorbing some of that magnetic force and it was impacting his pacemaker. And the pacemaker was thinking like, oh, I need that to sense because I'm getting this electrical activity, right? I also worked hospice for a little bit. And this magnet, you can see it says Medtronic on it, right? This magnet is what we use when we need to deactivate a pacemaker. So something as simple as this magnet, now granted it's pretty high powered, but it still also holds stuff to my fridge. So I mean, it's not like a super magnet, is enough that it can disrupt the electrical activity, right? So sensing, over sensing, we need to be aware it might be something faulty in the pacemaker or it could be something in the environment, right? Um, so if your patient is 100% dependent on their pacemaker, meaning they have had an ablation, they've had their SA node or their AV node, or there's something wrong there where it is dependent on both that AV and SA node impulses, right? It needs that first spike to get a P wave and a second spike to get a QRS. If there is something in the area, magnet, metal detector, roller coaster, microwave oven, whatever it could be, right? I'm not saying your microwave is going to set it off, but anything like that could compromise and you could have a risk for sudden death, bradycardia, all sorts of arrhythmias, because if they're 100% dependent on that and that pacemaker's not working, we could have a problem, right? Long story to say, got to be aware of your environment, lots of patient education so that they understand, right? Don't make the same mistake I did, which was send your husband on the Millennium and it doesn't go well. Okay. So that is what you need to know before you come to lab on Thursday morning. Okay. Next week, you're going to get another one of these little mini lectures, and we're going to talk about tachycardia and unorganized rhythms, right? So we're going to break this into chunks. We're going to talk about this tomorrow, Thursday at lab, and we're going to kind of digest this and go through it in a way that hopefully all the pieces start to come together and it starts to make sense. So I thank you for your time, and I will see you this week.